keep it quick. For those of you who don't know about Chris O'Brien Lifehouse, just very briefly, we are a purpose-built cancer-only hospital in Camperdown, Sydney. We are a non-for-profit hospital, and we have a very unique model in that we have funding to do some public work under breast and gynae oncology, and the rest, we are a private hospital and work alongside the coexist with RPA campus. So we look after all cancer or tumour streams, and I've got a list up on the screen. Hopefully everyone can see that. Within our hospital, we also have a very strong allied health services team, and I've got the list up there for everyone to be able to see. And this is available for patients to be able to access at all times. Now, we have set up a GP direct access line, and I have the phone numbers up there. So Monday to Friday, if you have a patient and you are worried and you just want to be able to sort out and get everything triaged and for a multidisciplinary team to be able to get everything in line for the patient, that line between 8 a.m. and 5 p.m. is 8514 0670. After hours, the line is 8514 0044. On the screen, you'll also have my email address currently and my mobile number. After hours is really anything 5 o'clock onwards and over the weekends. And the idea is that we can help triage and hopefully have a plan in place if you are seeing a patient and making that diagnosis over the weekend and we need to organise things for the patient. You can access us and we'll be able to get everything done hopefully as quickly as possible. So I'll keep it short. That's all from me. But if you do need those numbers later on, I'll leave those numbers with the PHN team and they'll be able to get them out to you. Thank you.
Thank you, Shireen. And now I would like to introduce our first speaker for tonight, Associate Professor Cherry Koh, who will be presenting on management of pelvic mesh complications. Professor Koh is a colorectal surgeon who works jointly at the Department of Colorectal Surgery in Royal Prince Alfred Hospital and Surgical Division of Chris O'Brien Lifehouse. I would like to also introduce another presenter who will joining the presentation, clinical nurse coordinator Mila-Rose Felipe at Benign Gynecology at Royal Prince Alfred Hospital, who will take her through the intake and referral pathways. Please welcome Professor Cherry Koh.
Thank you very much, Lydia, and thank you very much for the invitation to come and join you tonight. And I also like to acknowledge Mila-Rose, who's one of our CNCs who work with us on the pelvic mesh group, as well as Dr. Harpreet Arora, who is one of our urogynecologists. Now, I'm going to see if I actually, are you able to see my screen?
Yes, that's all good.
Yes.
We can see it.
All right, excellent. So what I've been asked to talk about is pelvic mesh related complication. And I suspect that majority of you would have had at least a patient who require some sort of prolapse related type procedure. However, pelvic mesh related complications are actually, in the grand scheme of things, not all that common, despite obviously what has been quite heavily advertised within the media. So hopefully tonight we'll give you a little bit of an overview about what's happening, a bit of an overview about some of the pelvic organ prolapse related problem and some of the problems they can cause. So I've been given the learning objectives tonight as that you would like to be able to recognize and manage pelvic mesh related complications. And at the end of this, you'll be able to put in place a coordinated referral pathway for appropriate cancer teams, which I'll come to later, because that's not obviously related to pelvic mesh at all. So what you can see here is that pelvic organ prolapse is very, very common. Up to 40% of women will have some sort of symptom because of pelvic organ prolapse, and it can be either urinary, vaginal, or rectal. And sometimes it's very non-specific in the sense that patients just complain about a pelvic heaviness. And about 11% of these women will undergo some sort of surgery because of symptoms of urinary incontinence or because of prolapse. There are lots of techniques that are actually available. The problem, however, is that when you try and approximate native tissue, it is no doubt the same age as the patient, it is stretched tissue, it is damaged tissue, and as a result, native tissue repair is associated with a high recurrence rate. And it is because of this that surgical mesh was thought to be beneficial, because it is going to increase the longevity of the repair and reduce the likelihood of recurrence. So surgery for pelvic prolapse obviously depends on whether or not the patient requires surgery, depends very much on severity of symptoms and the severity of the prolapse. Unfortunately, they don't always correlate, in the sense that some patients can have the worst prolapse but have minimal symptoms, and some patients can have a lot of symptoms despite not having a significant prolapse. A lot of it is about appropriate patient counseling about what we think is appropriate clinical management. In patients with mild symptoms or very minor prolapse, ideally, as we now know as a result of all these pelvic mesh related complications, that we should treat them conservatively with pessaries, with estrogen, topical estrogen therapy, pelvic floor exercises. Weight loss is actually a very significant thing. A lot of these older women who are postmenopausal do carry extra weight, and it's very helpful to actually lose some weight, which is also generally good for their overall health anyway. As a colorectal surgeon, obviously I see a lot of patients who have some sort of stool disturbance, either as a result of obstructive defecation, which I'll come to a little bit later on, or because of some minor soiling or fecal incontinence. And in these patients, a lot of it is about optimizing stool consistency, a biofeedback program, which the emphasis is not the same as pelvic floor exercises. The biofeedback program is all about getting the patient to evacuate completely. And that then obviously in combination with the pelvic floor exercises allows them better control of their bowels. No doubt some of these patients will still require surgery despite conservative management. And when surgery is required, there are, broadly speaking, three types. One is restorative, meaning to say that we're trying to basically plicate original tissue to try and use the endogenous supporting tissue to make it a little bit stronger. As we talked about, that unfortunately is associated with higher rates of recurrence. And then you've got the compensatory type repairs, meaning using a graft or a mesh to actually augment tissue strength to actually reduce the likelihood of recurrence. Now, one of the problems that we have encountered in patients with meshes, despite us running a mesh clinic, is that some patients would turn up not really knowing what they've actually had done. And the reason for that is because different terminology has been used. Some patients know that they have a graft. Some patients say that they have a gauze. Some say they have a sling. Some say that they have a tape. So a lot of terminology exists out there, and it's very important to understand what the patients actually understand by what they've actually had done. And finally, you've got the obliterative procedure, where you basically are plicating the vagina, stopping any further prolapse. Very effective, but clearly also not ideal, particularly in patients who still would wish to remain sexually active. This is just a diagram of the female pelvic floor. The one on the left here is basically to show you the pelvic floor perineal muscles, and the one on the right here is to show you a different view. One of the things that we obviously think about a lot is that we think about sort of we talk about episiotomies coming in this direction, sort of away from the anal sphincters. But what we also have to understand is that the pelvic organ prolapse literally is like a hernia. What we have to understand is that once the baby's head comes through the perineum, effectively the diaphragmatic, the hiatus of the perineum becomes much larger, and often patients can have asymmetry in the puborectalis or the pelvic floor muscle, resulting in some sort of asymmetrical bulge. And a lot of these patients have very low-grade symptoms in terms of dull, achy symptoms, very non-specific symptoms, simply because of the fact that this has been slowly coming on. Now, there are some important considerations when we're talking about pelvic mesh-related complications. I think it's very important at some point this evening that we talk about the different types of meshes and, of course, the different types of repairs, and also what the body actually does when mesh is actually implanted into the body. And clearly, we'll be talking about the different types of complications and obviously where to seek help. So surgical meshes, typically, broadly speaking, there are two different types of meshes. On the left here, you can see these are all what we call synthetic meshes. Some of them are actually proprietary, meaning to say that they come pre-shaped, as you can see here, or pre-fashioned in some way. And some of them are basically just a big piece of mesh that you can cut and fashion according to what you think is the size of the defect. And what you can see here are obviously more fancy pieces of meshes where there are anchoring arms that can allow you to anchor across the obturator muscle or alternatively into the ischial spine or towards the sacrospinal ligament. And obviously, this sometimes can be the reason why patients get pain, as we'll talk about later. On the right here, we've got the two types of biological meshes. By the name biological, it means to say that it's derived from an animal that is actually been hopefully treated kindly. I'm sure they are. What you can see here is that this actually is made by Cook. It's actually derived from the submucosa or the dermis of pigs, and this one here is actually also derived from porcine dermal matrix. So again, that is a biological material. Now, just to I guess not everyone may be familiar with how some of these anchors might actually be anchored into the patient. And I think this little video actually allows us some sort of appreciation as to why patients may get pain once the mesh actually contracts. We know that all scars, when you make an incision, scars contract. The same thing happens with meshes. Simply because the healing process is identical. It goes through inflammation, incorporation into the wound with fibroblasts, myofibroblasts, and that's what causes everything to contract. Same thing applies therefore to meshes. As you can see here, all these anchoring arms are to actually allow the pelvic floor integrity to be restored. However, if this contracts, you can see how it can start to pull on different structures if it's very tethered to a pudendal nerve or a different muscle, causing discomfort. Next slide. Now, so in terms of biological meshes, it's also very important to now distinguish that there are two subclasses within biological or biosynthetic meshes. The biological meshes are the ones that we've seen before. They are derived from an animal, either submucosal or dermal, either from pigs or cows, typically, sometimes from the pericardium, but that's obviously quite expensive and of fairly restricted use. A new category of meshes are what we call the biosynthetic meshes, which I actually believe is a bit of a misnomer. The reason why it's a bit misnomer is because the companies obviously are very clever. They like things that are biological because patients prefer something that is biological given the problems that you may have with synthetic meshes. However, biological products are clearly expensive. Because of that, they have come up with something that is purely synthetic, but it completely dissolves, and therefore they call it biosynthetic. Now, there are lots of these biosynthetic meshes available out there in the market, although BioA is currently the only one that is available in Australia. As you can see here, is biological in inverted commas, simply because it is not really derived from an animal, but it does actually absorb so that it completely goes away when there's actually any problem. Now, we've touched on about wound healing a little bit. I just want to, I'm sure this is bringing you back to your med school days of your pathology. Wound healing is a very orderly event. You make an incision somewhere, and what happens is that you're creating a wound. You create inflammation that then brings in all your macrophages, and then it brings in all your fibroblasts, your myofibroblasts, and that's what then allows your mesh to be incorporated into something to increase the strength of that material. Now, healing with mesh, as I say, is exactly the same thing. However, the difference is that there is now a foreign body. What we do know from material science is that if there is very intense or prolonged inflammation, this then causes excessive amounts of scarring because of excessive amounts of collagen that's being deposited. What then happens is that
Dr. Koh, your audio has disconnected.
Where you have rigid scar plate against very soft tissue, that's when you tend to get problems, and that's where you're going to get erosion and fistulation, and all sorts of problems happen because of that scar plate. Now, it's actually very difficult to actually get information from companies because no one wants to give up their secret recipe. But what we do know is that the material matters, the size of the pores matters, and the way it is woven together matters. For every single type of material, there is an optimal pore size and weave that gives you the ideal type of scar plate that is not too rigid and not too soft, in a sense that it then gives you the support that you need. The problem is that, you know, it's not always possible to predict how the patient actually deals with that. And one of the problems, as we have seen, is that I suspect that there's been a lot of adaptation from, you know, other sites of hernia, in the sense that we think that sort of reinforcing that would make sense. But unfortunately, adjacent to an atrophic vagina, which is deplete of estrogen and soft, as opposed to, say, abdominal wall, and that then causes probably excessive amounts of scarring, and that's why you get chronic pain, fistulation, and erosion. Now, just some pictures. I don't want to go into this too much at all. I think it's just important for us to understand why this occurs. It is just the way the body handles the mesh, in the sense that there was excessive amounts of inflammation, too much collagen. It's resulted in a scar plate. The scar plate pulls on nerves, and there are lots of nerves in the pelvic floor that causes chronic pain. And between the fixation points with sutures and where the scar plate is, that then causes, obviously the pelvic floor moves as well, that then causes an uneven distribution of load, and that then causes, obviously, the erosion. What you can see here is that they've tried to quantify this in a slightly more scientific manner, basically pulling it this way and that way to see exactly how that changes the pore size, what that does to the inflammation. And what you can see here is that some meshes will become, the pore will become very small. When you have a very small pore, what in fact happens is that you get a very big scar plate. The mesh wrinkles. When the mesh wrinkles, you get even higher density of mesh against a soft vagina. That just increases the risk of problems. I'm going to skip this. I think that's probably quite enough talk about material science, but it's all fairly interesting. This is just another video just to break up the talk a little bit more than anything else, actually, after my very, very interesting, but to me interesting, but possibly boring bit about material science. So this is another procedure, which is where a patient has vault prolapse. As you can see, the patient's already had a hysterectomy. And what effectively happens is that there is a Y-shaped piece of mesh, which is basically stitched onto the front and the back of the vagina, and that's hitched onto the top of the spine to provide support, and therefore hopefully reduces the likelihood of prolapse recurring. But you can also see why this then can cause problem, because you've got an atrophic vagina, you've got quite a lot of material, there's a bit of traction pulling the vagina up, and that sometimes can be the reason for problems. Now, we have all heard about the litigation associated with meshes. Everyone's a little bit concerned. There are, obviously, the focus of tonight is more about the long-term complications, because that's what has been in the media a lot, rather than the short-term complications. And some of these are listed there, and it includes erosion, chronic pain, or neuropathic pain. We'll come to each of these later on. I just wanted to list them down first. Patients can get dyspareunia, Patients can get functional problems as a result of the chronic pain, including obstructive defecation or fecal incontinence. And it's very interesting how the same problem can result in different symptoms in different patients. Some patients can develop fistulas, and there's been some queries that's been raised about immunological side effects of implanted meshes, although I have to say that it is not definitely proven at the moment in time with the pelvic meshes. I know that Dr. Nipu is going to be talking about this. I guess so far we haven't seen a pattern that is linking sort of anaplastic type lymphoma to particular types of breast implants, but who knows, it is still fairly early on in our mesh journey. And of course, we cannot forget the mental and psychological problems that patients can have as a result of these complications. And unfortunately, sometimes in the mesh clinic, we do see the same story repeating itself in the sense that the patients complain of symptoms, and yet they are told that it is in their head, there's nothing wrong with the mesh, and so on and so forth. Now, in terms of patient evaluation, so you've got a patient in front of you whom you suspect might have a pelvic mesh related problem. Now, clinical assessment is clearly very important. I guess one of the things about the clinic patients that we see is that by the time we see them, a lot of them are at the end of the road. Their history is very complex. Some of them have had meshes implanted 30 years ago, something taken out, something redone, and so on and so forth. Thorough history is very important. We try to go back and get as many operation reports as possible just to actually try and understand what has been done to patients, because we certainly don't want to be doing the wrong thing by them by offering repeat interventions that they do not require. We need to also look at their function. So typically from a bladder and urinary function point of view, this is urodynamics, and Dr. Harpreet Arora can talk a little bit more about that. For a colorectal surgeon, I find a defecating proctogram as well as anorectal physiology very important. A defecating proctogram is not something that patients like, but what it does is that it's the closest thing of me looking at how the rectum actually deals with the contrast, with them sitting on the toilet, telling me if they've got a rectocele, if they're actually retaining contrast, is that why they have that sensation of incomplete evacuation? Have they got a prolapse? How much prolapse is there? And so on and so forth. Imaging, I have to say, is very difficult. This is talked about in the literature by very enthusiastic radiologists, but I have to say that in my experience, I find it very difficult to image these patients, and I find it very, very operator dependent, particularly ultrasound. Sometimes you get lucky, you see the entire course of the mesh. However, the difficulty as well is that just because you can't see the mesh doesn't mean to say that I can or I should take it out, which is why I have not found imaging particularly helpful. MRIs, first of all, they are expensive, and also the difficulty is that you can't tell between scar versus mesh, and that's why I have gone away very much from using any imaging at all. Now, moving on to the first complication that we sort of listed, one of the things that we can see is erosion. As you can see here, this is a patient's vagina with a little bit of mesh poking through. Everyone can tell that that is a synthetic mesh. There has certainly been a bit of a move towards using absorbable mesh. However, just because someone has absorbable mesh does not mean to say that they are problem-free. What it means to say is that if it gets infected, that it will probably disappear. However, the scar tissue that it creates in the process of the mesh insertion can still be liable to symptoms. So therefore, just because we're using a dissolving piece of mesh or a biological mesh that's more expensive doesn't mean to say that it is risk-free. It could, however, have less problem in the sense that you may not have erosion because it should, in theory, disintegrate when there is infection. Depending on which part of the pelvic floor the erosion is occurring in, patients can obviously get slightly different symptoms. So if it's eroded into the urethra or the bladder, patients can get hematuria, patients can get recurrent urinary tract infection, or just dysuria. In patients where there is mesh erosion into the vagina, dyspareunia clearly is a problem. It's painful for both the female as well as the male partners. And sometimes patients come to us with a story of their male partners' penises being sort of injured or have little lacerations on them because of the mesh being exposed. Vaginal bleeding is another problem that patients can have, and we have to remember that most of these patients are postmenopausal, so it's clearly abnormal. Vaginal discharge, vaginal infection all goes along with the territory, and sometimes patients can say that the mesh is extruded. They get little bits of fiber when they pass urine and so on and so forth. And I think pain is one of the most disturbing symptoms and one of the most difficult to treat symptoms. And this is just the three pictures here I have here is just to show you the different ways of, for example, putting in TVT tapes. This is to support, this is kind of a mid-urethral sling for urinary incontinence, which I have to say is still the best treatment for urinary incontinence. Just because we have mesh-related complication doesn't mean to say that we need to throw out the baby with the bath water. Certainly for anterior compartment prolapse, the mid-urethral sling has been proven again and again to be very effective, provided it has been inserted properly. However, as you can see here, there are different techniques of insertion. This is the standard TVT, which is much more like a U shape, and then you have a more like a sort of V-shaped type, slightly broader U, I suppose, with the TVT through the obturator muscle or the obturator membrane. That is associated with less problems. However, patients, because of that being anchored into the groin or the obturator muscle, patients can actually get a very intense groin pain, especially with contraction of the meshes. So knowing what sort of procedure, what material, and also how it was inserted is obviously important. Chronic pain management is very important. As you all know, we all follow the analgesia ladder. A lot of patients would tell you that something doesn't do something, you know, that you try the Panadol, you try the Nurofen, it may not help. But I do think that it's very helpful, regardless, in reducing the amount of opioids that patients would need to use. And I have to say that most females I have met are quite sensitive to opioids. Some get dependent on it very quickly, particularly with chronic pain. And most women want to avoid opioids because a lot of women that we have met still have child sort of responsibility in terms of looking after the household, and they don't want to have that foggy head. I find neuroleptics very helpful, amitriptyline, gabapentin, and obviously the newer agents such as the partial opioid agonists, allegedly less addictive, such as tapentadol, are useful, particularly in the long term. Involvement of pain specialists, I think, is vital for these patients. It is also very important for us to consider non-medical therapy, which is typical of any chronic illness management, including an exercise program. And we also need to focus on managing the depression and the anxiety that goes along with the diagnosis and the problem of chronic pain as well. The pain, when it's not well managed, unfortunately, then can cause more bladder and bowel dysfunction because of pelvic floor spasm. Certainly from in my world for colorectal surgery, a lot of patients, because of pain with defecation, they would deliberately avoid fiber, or they don't want to drink too much because they don't want to pee too much, and so on and so forth. This unfortunately then makes their bowel worse, which then often makes the spasm worse, although they think that this is actually helping their bowel function. Patients often prefer laxatives because they find hard stools are difficult, but too much laxatives obviously can also be a problem because it then exacerbates the problem of incomplete fecal evacuation. Now, what is the etiology of chronic pain, given that it is such a big problem? We think that a lot of it is related to mesh contraction over time because of the myofibroblasts. However, some meshes can also be placed inappropriately, and we certainly have patients who tell us that we woke up in recovery with basically immediate pain. So that is probably because it's either passed inappropriately through a different structure, a slightly different course, or too close to something else, a hematoma, or alternatively, the tension is simply too tight. It's often multifactorial in patients with long-term chronic pain. Sometimes patients are very good, their urinary incontinence is dealt with, is managed for 2, 3, 4, 10 years, and then they subsequently develop problems because the meshes contract over time. And one of the difficulties, I guess, with chronic pain once it is established is that it can persist even after mesh removal because of scar and the persisting inflammatory changes that occurs, which is why I find a multidisciplinary approach very useful, including management of the chronic illness, involvement of a pain team, and a physiotherapy. I certainly have had patients who have had meshes placed through the sphincters, and that's why their anus is basically chronically spasmed, and that's why they have severe pelvic floor pain. And I think knowing the technique and the type of operation where the mesh is supposed to course through is very helpful. So this is just a little picture here. As you can see here on the picture A is a implanted mesh, or the apogee mesh. And this is actually the apex of the vagina looking inward. What you can see on the right hand here is that over time, it basically contracts. As it contracts, it pulls on the arms a lot more. And we have to remember that there are very few structures that these meshes can be anchored onto. One of the classical spots is actually the ischial spine, or the sacrospinous ligament. And we all know, therefore, that the pudendal artery and the pudendal nerve courses just around that. And that's why patients get a very bad neuropathic pain. What about fistulas? Patients can get fistulas if you erode on both sides, so not just on one side, such as a vaginal erosion, but if you erode both on the vaginal side as well as the rectal side, for example, and suddenly you've got a rectal vaginal fistula. The diagnosis is normally pretty clear-cut. You normally have either urine discharge or fecal material or flatus passing out vaginally, and it's typically the result of a scar plate causing erosion. What are some of the bowel problems that we may see? Now, we also have to remember that in patients with pelvic floor problems, that you do not always have mesh-related complications. It could be. We need to keep an open mind. However, just because you've got prolapse in one compartment doesn't mean to say that, I mean, you can certainly still have prolapse in another compartment subsequently, because it's all subject to the same problem of aging, loss of estrogen, and also of childbearing. So as a colorectal surgeon, obviously I see a lot of patients with fecal incontinence, which is obviously defined as unintentional loss of flatus or fecal material. But in some patients, it can just be related to a little bit of soiling because of that incomplete evacuation, more related to obstructive defecation. A lot of patients dislike fecal incontinence. What you will find is that a lot of patients will learn to manage the bowels. Your fecal incontinence doesn't become so bad if you then take laxatives once a week, twice a week, 3 times a week, or whatever it is, and you basically stay home that day or the day after you've taken all these laxatives. So some patients don't always volunteer the story of fecal incontinence because they have learned to manage the bowels so that they never run the risk of fecal incontinence. Obstructive defecation is the opposite. So this is basically patient, I'm sure a lot of you would have seen this independent of meshes in sort of postmenopausal women who basically have non-ideal stool type with a rectocele, where they have the inability to basically completely evacuate fecal material. They strain more, they have that uncomfortable feeling that something is still left behind. And because of that excessive straining, they then give themselves secondary hemorrhoids. So whenever I see hemorrhoids in someone who's older, I always ask myself, is this because of an underlying obstructive defecation, or is this genuinely because of hemorrhoidal disease? These patients always complain of a sensation of incomplete evacuation, and they typically have increased stool frequency. And this may come and go. On a good day, they get good days and they get bad days. And one of the problems is that, you know, is this the chicken or the egg? Is the bowel effect related to a de novo prolapse in a different compartment, which is completely unrelated to the mesh itself, or is it actually related to mesh? And what I find very helpful is initiating something that is simple to see how they go. And I think serial assessment, even if it's a phone call to see how they're coming along, I get them to send me an email. Mila Rose is very helpful. She keeps in touch with the patients and she will tell me, this is not working, that's not working, let's tweak something else and see how we get on. Now, assessment of bowel symptoms, again, very close to my heart as a colorectal surgeon. Always look at stool consistency, always ask about symptoms, ask about their diet, ask about their oral fluid, their caffeine intake. A lot of these patients are a bit older. They prefer their tea, they prefer their coffee as their drink of choice. They don't actually have that much fluid, also because they have problems with urinary incontinence. Very important to encourage them to actually make sure that they drink enough fluid. In terms of their bowel habit, also very important to ask them about what they use in terms of laxatives, what's their stool frequency, do they get any urgency, and so on and so forth. Autoimmune problems, as I said before, that
Professor Koh, we lost your audio. Professor Koh?
Which is the association between implant and poorly differentiated lymphomas. Finally, in terms of management, I think a multidisciplinary approach is very important. We have a big team of urogynecologists, including Dr. Aurora, Professor Christopher Burness, Dr. Vivian Yang. There's myself, colorectal surgeon. We've got nurses, we've got dietetics, physiotherapy, social work, pain team, biofeedback therapy, and so on and so forth, just to basically cater to the patient's needs. I can't actually see my slide because I've got this thing in my way, but I think I'll also say psychology as well. The basic management of these patients involves typically at least an exercise program, managing their depression and anxiety, making sure that they're actually counseled appropriately. A lot of patients have actually come with a lawyer's letter, which is often very intimidating. And in a way, the lawyer is very helpful because they often come with a stack of documentation about an inch thick, listing out all their different operations that they have had and different pathology and so on and so forth and different investigations. Despite that, it is still very intimidating because you fear that one day you'll be subpoenaed to provide evidence. Pain management, I think, is very important. This is sometimes one of the most difficult things that we have for these patients in terms of trying to get them to see a pain specialist in a timely manner. And we get them to start on simple things in terms of bulking agents or such as fiber supplementation or laxatives or suppositories to manage the bowels. We've got to make sure that while they are waiting for their workup, that their life is manageable. Patients come to us having suffered for a long time. I think that it is only fair that we ensure that their symptoms, while they are waiting for all these different investigations, we can take time, it's actually manageable. And finally, surgery to consider mesh removal. Now, we don't take this lightly simply because, as I said, it might sort out the fistula or the erosion, which are clearly important things, but it often does not completely get rid of the pain for these patients. In terms of surgery, one of the things, of course, is that if the mesh was put in because of a prolapse, once you take that piece of mesh out, the concern obviously is that you now have recurrence of the symptoms, and what do you have up your sleeve to actually manage that? Or are they going to be in a worse off position where they then have to battle their urinary incontinence, different types of prolapse? What are we actually going to do? Unfortunately, as I said before, there are too many familiar stories in the clinic that we come across in terms of delayed diagnosis. A lot of patients come to us saying that they've been ignored for years. They were told that the symptoms were in their head. They have seen multiple specialists in a very ad hoc manner. Go and see Professor so-and-so, go and see this person so-and-so. And patients have driven many of kilometers. We get patients who have driven up to Queensland, with patients who go up to the United States, even for mesh removal, having reverse mortgages, which unfortunately is all too familiar to us. This obviously comes at a significant financial as well as personal cost, not just in terms of symptoms, but also literally monetary cost. A lot of patients have lost their jobs because of inability to work, dyspareunia, therefore relationship breakdowns, and that sort of stuff. It's very important that we try and engage our social worker to try and provide them with the support that they require. And many have also come to us with, in a way, I find unhelpful diagnostic tests because the MRI says that the mesh is nowhere near my nerve. I mean, it doesn't help anything, does it? Because the patient still has pain. But I have to also remind us and myself that there are always two sides to a story. For some patients, the symptoms are definitely not related to mesh, because as I say, if you can develop prolapse somewhere, why is it that you can't develop prolapse somewhere else? And in fact, the de novo prolapse is actually the cause of the symptoms and is unrelated to mesh, but we have to keep an open mind. We have unfortunately also seen patients who are seeking compensation as part of a class action, despite the fact that they actually have no symptoms related to the mesh. So therefore, I feel that assessment by an experienced MDT is important. Now, that may not be very helpful to you out there as GPs. What do you actually do? I think that you need to listen to your gut feeling. If a patient comes to you with a symptom or a constellation of symptoms that is not typical, is persistent, and you don't think that the specialist is able to actually explain the symptoms, consider a second opinion. Your patients will be very grateful. I'm not encouraging patients to obviously doctor shop, but I think that sometimes that reassurance to make sure that it's nothing else is also very helpful to the patient. The symptoms to look out for obviously are the ones that we talked about, particularly pain, dyspareunia. All of these symptoms are not normal and should be investigated. And the last thing I want to say as well is that we know that meshes are efficacious, particularly for certain types of incontinence. Just because of what we do, I certainly am not advocating that we completely throw mesh out of the picture. The important thing to recognize is that mesh use for middle compartment prolapse is much less established. For my purposes, meaning posterior compartment prolapse, for example, for rectopexy, it remains the gold standard, particularly if you're fit and well. Although I have to say that there's now increasing move away from synthetic meshes because of concerns that the class action is one day going to hit colorectal. I think that technique also matters. And what I've got there is a chimpanzee who is apparently Michael Jackson's chimpanzee, very talented, drawing a little painting, but clearly, even though we are in awe, that is not the same as the master who drew the Starry Night on the right. So technique is important. I think having a well-qualified and well-trained urogynecologist is very important. And I also do think that one of the things that the TGA and the College of Obstetrics and Gynecology have found is that they have realized that they probably need to look at issues of accreditation as to who is allowed to implant meshes. Now, finally, coming back to referral pathway, if there's any patients that you're concerned about, we're very happy to assess them. A lot of consults are done via Zoom these days because of COVID-19. We've got the pelvic mesh clinic. Our CNC is Mila Rose, who is actually on the line, ready to take all questions that you may have. We emphasize a multidisciplinary approach. She takes a history from the patient and basically directs them to whichever specialist needs to see the patient based on what the patients tell her. So hopefully I have addressed your learning objective number one, that you understand the symptoms to look out for, which are pain, discharge, bowel problems, urination problems, dyspareunia, particularly if you've got more than one symptom and it is persistent, that is not normal. I hope you have a basic understanding of how meshes work and how a scar plate may cause erosion, fistula, and chronic pain because of mesh contraction, and the problem with the scar plate buckling and wrinkling of the meshes because of points of fixation. We've got a referral pathway. I'll show you the contact details in a second. In terms of initiating investigations and management, I think it depends very much on the symptom, as we've talked about. If they have urinary symptoms, it's important they get some urinary culture. I would start with very simple things of Ural to try and manage this, Ditropan for hyperactive bladder. Start with pain management, which is ideally non-opioid based, such as a partial agonist, such as tapentadol. Bowel management in terms of optimizing the stool consistency, increasing the oral fluid intake, reducing caffeine intake, and so on and so forth. Engaging a pelvic floor physiotherapy. I understand that physiotherapy, unfortunately, is very costly, and a lot of patients find it very, very difficult to afford. I understand that GPs have the ability to write a plan, which makes it much more affordable for patients, which I think is very helpful. Management of the depression and anxiety is also very helpful. Very quickly, I'm just going to touch on learning objective number 2, which is clearly independent of the mesh pathway, which I understand was all about coordinated referral pathways with cancer. As a colorectal surgeon, I can only flesh up this slide, which is a slide that I show patients when I'm in rooms to tell them about the management algorithms of stage 1 to 3 colon and rectal cancer. As you can see there, colon and rectal cancer treatments quite different, and apart from diagnosis with the colonoscopy, they require staging. For colon and rectal cancer, everyone needs a CT scan of the chest, abdomen, pelvis. But for the rectum, you also need an MRI as well. Then consideration of whether or not patients require straight upfront surgery versus chemoradiotherapy, followed by surgery for the rectal cancers. But for colon cancer, in patients who do not have distant metastasis, it is invariably upfront surgery, referral to a colorectal surgeon. And it's only after that, based on the histology, we decide whether or not patients require chemotherapy. So that's just a little snapshot in terms of what happens with stage 1 to stage 3 colon and rectal cancer patients. Stage 4 patients are managed very differently, depending on whether or not their metastasis is resectable. I'm very happy to take any questions, and these are our contact details for myself, Dr. Aurora, as well as Miller Rose. Thank you very much.
Thank you very much, Professor Koh. I would like to ask Miller Rose to present on referral pathways and over to you, Miller Rose. Thank you.
Hello, can you hear me?
Yes, very well, thank you.
Excellent. Sorry, I'm just getting my screen all set up. Good evening, everybody. My name is Miller Rose Felipe. Thank you, Cherry. So I'm the clinical nurse consultant for the pelvic mesh service, and thank you for inviting me to present on the referral pathway for the RPA pelvic mesh service. So here I've got, so there's actually 5 New South Wales pelvic mesh clinics. So of course there's one in Royal Prince Alfred Hospital, Nepean, Royal North Shore, St George and Westmead. I've also included the contact details there for you. Here I've got the RPA pelvic mesh service patient referral form. How to access this or locate this, please go to the Health Pathway Sydney, go to search, type in pelvic mesh service, click on the PDFs, forms, documents, and then you can click on the RPA pelvic mesh service referral .pdf, and that's where you'll find this form. Sorry, I can't see my, I'm just gonna put my camera down so I can't see my presentation, sorry. There we are. So the referral letter can be addressed to Dr. Andrew Browning, the fax I provided there. With the urgent referrals, we can see the patients within 1 to 2 weeks and non-urgent within about 4 weeks' time. So hang on, I can't click onto my next screen. We also accept GP referral letters, obviously with patient details, relevant patient history. If you can provide patient implant operation details, mesh removal operation details, any previous tests and procedures that they've had done, and if they've been referred to other services, that would be great to add, and any medications that they're currently on. So the clinic pathway, we've divided it in 4 parts. That's access and referral, assessment, management and treatment, follow-up and discharge. Here I've got access and referral. So the referral we receive from GP and other specialists. The referral has been triaged by the Korean medical officer, which is Dr. Andrew Browning and myself, the clinical nurse consultant for the service. The CNC will contact patient to discuss service offered. So we have social work, physio, clinical dietitian, and clinical psychologist. The CNC will assess if referral is required prior to the clinic appointment. Clinic expectations. So realistic patient expectation needs to be discussed to prevent any disappointment. Appointment details and other medical information required for the consultation is also discussed. CNC will send relevant information such as any clinic map, concession parking, and appointment details prior to them coming to their appointment. So with the assessment, the clinic is multidisciplinary, as Cherry Coase mentioned. It is led by a urogynecologist, Associate Professor Christopher Benes. So our consultation starts with the skills and attitudes of staff, including empathy and respect for the client, a non-judgmental attitude and sensitive to the client's journey. The client's consulted by a career medical officer and the clinical nurse consultant. The initial consultation takes approximately about 2 hours. In that 2 hours, the CMO does an extensive chronological history, a pelvic, vaginal examination, and then management plan is then discussed. A follow-up appointment is usually 1 hour. At the end of that, patients given education information during and or after appointment. They also get a little food pack because the day is quite long just before they go home. So depending on the client presentation, the CMO may refer to a urogynecologist, colorectal surgeon, urologist, immunologist, pain management, as well as neurologist. If not already referred prior to clinic appointment, the CMO can also refer the clients to social worker, clinical psychologist, clinical dietitian, and physiotherapist. The CMO may order 3D, 4D ultrasound, urodynamic studies, and cystoscopy. That's done in Sydney Urodynamics, MRI, ultrasound, and as Cherry Coase mentioned, with if Cherry sees them, usually the biofeedback, anorectal physiology, and DPG. Conservative management is always offered as first line of management, and if that does not work, obviously surgical management is then offered. Individualized treatment plan developed in consultation with the patient is based on their needs. So standard for the follow-up and discharge, standard reports sent to GP specialists and allied health. Patients booked in for appointments at determined time frame, and patients usually followed up by the CMO, CNC at periodic intervals via phone, face-to-face to monitor their progress. They also all get followed up with the specialist that they've been referred to as well. So reported symptoms that presents in the clinic is women have, so reported symptoms, so women who reported complications from the transvaginal procedures have described the range of symptoms. So chronic pain in the pelvis, lower back, hip and thigh, or a combination of these are very, very common presenting to our clinic. They're also becoming aware of the mesh during intercourse or experiencing pain during sex for the woman or her partner. Vaginal bleeding, being able to feel the mesh in the vagina or having pain or prickly feeling. Having blood in the urine due to erosion of the mesh into the bladder or urethra. Recurrent urinary or vaginal infection. A foreign body response. Wound breakdown, extrusion, erosion, exposure, fistula formation, and or inflammation. Some women report experiencing autoimmune disease following the treatment with transvaginal mesh, but at present there is no scientific evidence to support a link to autoimmune disease. So as mentioned earlier, management plan, so conservative management, medication, physiotherapists and other physical therapists, pain management, surgical management, examination under anesthetic, mesh revision, excision, and removal. Lydia, I can't go to the next slide.
Would you be able to, would you agree to pass your notes to our attendees today? This
Yep.
way we can pass on the rest of the information.
Yeah, it's just my contact details at the end anyway. The presentation's finished.
Fantastic. Fantastic. Thank you very much for the comprehensive referral pathways. I would like to present, to introduce rather our next speaker, Dr. Nipu Jayateleki, who will be presenting on reconstruction after breast implants go wrong. Dr. Nipu is breast surgeon at Chris O'Brien Lifehouse, specialist in breast oncoplastic, endocrine, and general surgery. Please welcome Dr. Nipu.
Hello, good evening. So we go from well below the pubic symphysis to up high again above the xiphisternum. When I first got approached about this talk, I got asked to talk about reconstruction after failure of implant reconstructions. Now that's a super subspecialty, very plastics area. And I was thinking about what would be beneficial for general practitioner colleagues. And I actually spoke to a couple of my GP friends, and they were very interested in the overall picture of breast implants. So I thought I'm going to present useful tools for you to manage these patients in your rooms as well. So let me just see if I can get this working. Excellent. So a little bit about me. I'm an oncoplastic breast and general surgeon, and I do endocrine surgery as well. And what oncoplastics means is that we use plastic surgical, I'm an oncological surgeon, but I use plastic surgical principles to give better cosmetic outcomes for patients along with their oncological surgery. And my practice is focused around teaching. I do a lot of teaching with the IAS and the surgical skills department there. I'm the deputy director. I really pride myself on leading in particularly in the women in surgery and mentorship and younger fellows groups within the College of Surgeons. I'm definitely an intersectional feminist. I look at getting diversity and women in surgery, and I'm a collaborator. I like to think of my practice as something where I work with GPs and all my other colleagues for the best outcome of our patients. So I'm at Chris O'Brien Lifehouse, and I'm a private surgeon there. And I'm also at Integrated Specialist Health in Miranda, and I operate at a number of different places around. So that's a bit about me. So what I wanted to give from this talk was understanding implants. A lot of my colleagues, who are even my surgical colleagues, are trying to get their head around where we put them, how we choose them, what do they all mean, some of the reconstruction choices, so that you understand when you see one of our patients post-operatively in your office, what they've actually done. How did I come up with the idea of choosing that particular surgery? We'll definitely cover some of the adverse events that can occur following implant surgery. And most of all, now that you know all this information, I want you to be empowered to be able to see a patient who has implants for either augmentation or reconstruction, and be confident and comfortable about assessing them and knowing when to seek help and who to call. So just to start with, some implant basics. So the cosmetic breast augmentation is the #1 procedure, cosmetic surgery procedure worldwide, and up to something like 20,000 women have this procedure done in Australia every year. So that's a lot of implants going in. Small proportion of those are our patients who are breast cancer patients after a mastectomy, but a lot of young women putting in implants for augmentation purposes. So obviously my world, my angle is post-mastectomy reconstruction. The indications are cosmetic, post-mastectomy, congenital deformities of the breast, like Poland syndrome, where you have essentially maldevelopment or failure to develop of the pectoral girdle, so you can not have the pectoralis muscle, sometimes the chest wall not develop, but also the breast not develop, and a few other syndromes like that. So with all of this going on, there's a fantastic initiative that was spearheaded by Monash University Group called the Australian Breast Device Registry, and we encourage all patients to sign up for this, and reputable surgeons should really be actively involved in this, where we make sure that all the information around the various breast devices we put into patients are logged, so that if there are any issues in the future, it is easy to chase them up. We have all the information at hand. So that's just an explanation of where we're at. Just to understand implant reconstruction, it's been a long process in development. You may remember the Zerny retractor from your travels through surgery back in the day. Basically, the first attempt at a reconstruction was back in 1895. Vincent Zerny put a lipoma from the patient's flank or buttock into a mastectomy wound, and in those bad old days, they were doing mastectomies for benign disease. Implant-based reconstructions really began in the 60s. In 1963, Cronin and Gerow, two plastic surgeons in Houston, Texas, they performed the first implant augmentation using Dow Corning implants, which you can see. I don't know if you can see a cursor on your screen, whether my cursor comes up, but basically those are the original Dow Corning implants. Some things have changed, some things have stayed the same, and you'll see what I'm talking about in a minute. So Cronin and Gerow started doing delayed implant reconstructions, and it was only in the 70s that a couple of other plastic surgeons spearheaded doing immediate implant reconstructions. And I promise by the end of this talk, you'll understand what I mean by those terms. So when we look at a reconstruction, how do we decide what we do? There's a host of factors, which is why you've probably seen a constellation of different reconstructions. Everyone comes into you with an implant-based recon, but they've all had a different pathway to getting there. Obviously, the overarching thing with all of this is patient choice, and making sure, I think every patient in Australia who has breast cancer should be given the option of reconstruction should she go to a properly trained breast surgeon. It's very important for their we know that good cosmesis, there's loads of studies. We know that good cosmesis has excellent outcomes for patients in terms of their psychosocial well-being long term. So in terms of what we look for, I tell patients, you know, sometimes disease factors means that we don't get all the choices that we want. Other times it's patient factors. So the disease factors are fairly obvious ones. If the tumor involves the skin, the nipple areolar complex, if I think that they're going to need post-mastectomy radiotherapy, which is PMRT, or that they might need neoadjuvant chemo versus adjuvant chemotherapy, all of these things change when and how and what I offer for patients. In terms of patient factors, the patient's intended breast volume makes a difference, what is achievable. Ptosis, which is the degree of droop of your breast. As you get older, your breasts head south, and it's just correcting for that. Body habitus does matter, not so much in anything else, but really in terms of giving them an aesthetically pleasing proportion. So if you have a larger frame and a wider chest, putting smaller implants on won't look necessarily as proportional as perhaps a soft tissue autologous reconstruction. And of course, finally, patient comorbidities are a significant factor. So I certainly would not be offering upfront reconstruction for someone who is a smoker, and other comorbidities like diabetes definitely raise the risk factor on these procedures. So these are the things going through your mind. So you really want to make sure that your surgeon is on top of oncological management as well, because I need to predict how this tumor is going to behave in how I choose my upfront surgery. In terms of planning it and what I use, there are three different aspects we look at. The timing, whether we do it immediately, that means at the time of mastectomy, or whether it's delayed, and there's a number of options in that, and delayed can be anywhere from a few months to even a few years if the patient needed it. The placement, whether it's subpectoral, that means below the pectoral muscle, or prepectoral, above the pectoral muscle. Sometimes you'll hear the term subglandular used for patients who are having breast augmentation for cosmetic procedure, where they actually place the implant below the breast but in front of the pectoral muscle, and we'll run through that again. And of course, what the filler material is. Are we going to give them an autologous soft tissue reconstruction or an implant-based reconstruction? It's usually one or the other. Occasionally you might see patients from the past where they have a combination of perhaps like a latissimus dorsi flap and a half-size implant. Not really something that I would offer at the moment currently. And I just want to spend a few minutes here just to explain to you what exactly all of this means. And I apologize if you cannot see I have no idea whether you can see my pointer or not, but basically this is a picture I pinched from the internet. So sorry about the copyright, but it gets the point across. Basically, when we
see your pointer, Dr. Nipu, just to let you know.
Thank you.
Yes, fantastic. Thank you.
No worries. So when we do a subpectoral implant reconstruction, and remember that there's 1,000 different ways that we can actually do the mastectomy, I prefer to do mine ideally. For me, the most cosmetically pleasing is when you preserve the nipple and skin envelopes in what we call a nipple sparing mastectomy, and I tend to make the incision in the underwire line, which is the inframammary fold. That's the term we use. Basically what you do is you do the mastectomy, you raise the pectoralis major muscle, you tuck your implant in, and in real life it's not quite as clear cut that you can see, but this illustrates the fact that the pec doesn't quite cover the implant. So we end up using a mesh, and thank you, Cherry, for having already covered all the mesh issues before. We use some form of mesh, and it can be acellular dermal matrix, so some sort of a biological thing, including something called Flex HD, which is cadaveric tissue, all the way down to titanium coated loop meshes. And essentially the implant gets we create this, we call it a bra pocket, and we create this little pocket. The idea of the pocket is really important, and as you'll see in some of the complication slides we talk about, because we want it to be a really perfect hand in glove. And unlike other types of surgery that we sometimes do, there's no fixed plane that you go on. There's a lot of aesthetics involved and a lot of feel and judgment with your eye in terms of making sure you've got the size and shape appropriately. And in our world, in the world of reconstruction, I don't have a lovely breast mound to work with. I've already taken the breast away, so I have to do this from scratch. So the implant gets tucked in there. You've got the mesh covering it all up below the pectoral muscle, and that's how it sits. This is quite an involved procedure. There's a higher risk of bleeding and seromas. It does give a lot more protection for the implant, but it is quite uncomfortable, and patients are in hospital for a couple of days. They need a reasonable amount of analgesia. I've shifted towards doing prepectoral placement if possible now, and prepectoral basically means it's in front of the pectoralis. It's a lot faster. There is about an hour to an hour and a half's worth of dissection involved in raising that pectoralis major muscle and tucking the implant in. That cuts down operating time. Patients are a lot more comfortable because you're not elevating muscle, and aesthetic outcomes are pretty good. It's not for everyone, but in selected patients, I definitely think that this is the way forward for us. And essentially the implant goes in front of that tissue. So you can see already that you've got patients who might come to you with reconstructed implant-based recons who have very different placements, and how what you're examining is quite different. So the other thing I wanted to give you an understanding of is how do we choose these implants? There's like a million different kinds out there, different brands, blah, blah, blah. Look, to be honest, at the end of the day, most of us emerge from our training and our various postgraduate fellowships and so on, preferring a particular implant that we probably trained with. But there is definitely a method to the madness in how we choose something, and as you become more experienced, you might move away from that into something different. But we basically, when I'm talking about an implant with someone, and this is important because you'll be thinking about this when you take implant histories in your rooms, we talk about the surface, the shape, and the fill material. So the surface can be textured or smooth. We use them in different contexts. They can be anatomic versus round. And what that means is round implants, you can see the ones here, they're literally round. You can put them in, they can spin around, it doesn't really matter. It doesn't matter how you put them in, they're gonna be in the appropriate position because they're round. Anatomic implants is what I use because my patients don't have a breast mounted tuck a round implant behind. Round implants tend to get used a lot in cosmetic augmentations because they don't have to worry about breast shape. They're just trying to increase the projection of the breast. I have to use anatomic implants most of the time, and anatomic implants have this lovely soft teardrop shape. And orientation is obviously very important. If you put it in the wrong way, you will have a very lopsided, weird looking breast, and you do not want that. So orientation of that is super important. We use a whole bunch of different ways of calculating what size someone needs. There are a million different variations within each implant category, and we basically look at everything from the height to the width to the arc distance to get the right projection and match the other side. The other thing that we talk about is the fill, whether it's silicone versus saline. Look, saline implants, they still get used overseas a little bit, and I think in the States they get used. They're safe. If they rupture, the saline just gets absorbed into the body. It's not dangerous, but we don't really use them in Australia. We use silicone implants in Australia, and the current generation of silicone implants that we use are CPG, cohesive gel implants. And the difference between that and the old implants that you'll have heard about, the Dow Corning ones and the PIP things, they are what you'll hear patients talking about, the gummy bear implants. It's essentially when you pull the implant apart, they're really hard to rupture, but if you sit there with a pair of scissors and you open it up, the silicone does not flow out. It remains stable. So it's quite safe in that sense. They are hard to rupture, but if it does happen, it means that silicone isn't going everywhere in their chest wall cavity. The other thing that we look at is the size of an implant. So if I say something like there's a 300cc silicone implant, that just means it's a 300, the cc is in cubic centimeters, it's a roughly 300 ml silicone implant, and that's how we talk about volume in the breast. So that's just so you have an understanding of what we look at. I just want to touch on tissue expanders, because in my world of reconstruction, we definitely use these, and you've probably seen patients who've come in with tissue expanders. I describe them to patients as a space saver for the final reconstruction, and my choice of expander versus an immediate implant is based on all those patient and disease factors we spoke about. Sometimes it's not safe or appropriate to put in the final implant or even soft tissue reconstruction into your mastectomy space. That might be because a tumor factor, you think, okay, well, this person's going to have radiotherapy. Radiotherapy doesn't play nicely with our implants and our reconstructions, although it's fantastic for our breast cancer patients who need it. And chemotherapy is not always great, so we might put in something like an expander. It takes the pressure off. It just allows us to gently expand that space up over a period of time. And it also means that if there is a problem, and we'll get to that in a few slides, we can remove it and not have sort of wrecked the implant option, as it were. So generally, the cool things about this for your rooms to know about is, so you can place them pre or subpectoral as per normal. And generally what happens is, I try and fill it up on the day as much as I can, but traditionally what we did was we would bring the patient back into our rooms, and weekly we would give them 50 to 100 ml aliquot. Some patients can tolerate even more, where we inject the saline into the expanders and allow it to expand up to the appropriate volume that is predetermined. They're not forever. You have to remove them generally by 12 months. Usually we use them as a bridge to something, whether it's bridge to get through radiotherapy or whatever other risk factors they had. Sometimes I will put air-filled expanders in if this doesn't happen very often, but if I'm worried about the skin envelope, it's very thin, or the blood supply is compromised in some way, I'm worried about it. An expander filled with air is a nice option because it's light, it puts no pressure on that delicate flap. I can let it all heal over and then come back at a later date to tuck it in. For you in general practice, what you need to be aware of is, what they are. The fact that when you put an expander in, I always warn patients, it looks terrible. It does not look like the final deal. It's all lumpy, it sits weird, and that's okay, because that's not what they're supposed to do. We don't want them to sit in the full implant space. We want them to gently splay out the pole of the breast that we're interested in expanding out. And they work just like a portacath. You can see there's a metal plate with silicone over the top. We access it through the skin. This cool little magnetized device helps us find the center of that. pop a needle in, inject your sterile saline. I tend to use 2 mils of patent V blue dye because I think I put that into the saline solution in the operating theater, and that just means that if there's any issue of seroma or something like that, and someone's trying to aspirate it, if they aspirate back blue dye, you know you're in the right space. It's just a simple thing that you can do. So the only reason I'm putting that in there is if any of you were to have one of my patients and something happened with this and you wondered about that, that's why it's in there. So just a quick summary of implant evolution. I won't go into in detail, but all the way from the 60s to the modern 5th generation form stable cohesive gel implants, a lot of the generational changes has been about changing the complications, which we're going to talk about. The early generations, there was a lot of capsular contracture, which you will understand at the end of this talk, bleeding of the silicone gel, which is a problem, early ruptures. Ruptures like pretty much don't happen with these anymore. And capsular contracture has markedly decreased with all of this. So that's really the progression. So through that whistle-stop tour of implants, I want to talk to you about some of the adverse events that can happen following breast implant surgery. Unlike diamonds, implants are not forever, unfortunately. They're not lifetime devices. And I think sometimes I worry that some of the younger women who go and have implants aren't always, for augmentation purposes, aren't always aware that these are not lifetime devices. You're signing up for annual follow-up and you're signing up for revision surgeries. So they need to really be aware of that when they go into that into this. One of the biggest questions I get from patients and from other colleagues is when implant manufacturer says their lifetime, like their guarantees for 10 years or 15 years, does that mean the implant is some way compromised? And the answer is not really. The implants themselves are quite stable. You can have an implant for decades if you wanted to. It's the implant-related cumulative adverse events like capsular contracture and a few other things that we'll talk about. They are the reason for people to have revision. So usually by the time patients get to about 10 years, they've definitely started to get some of these complications we'll talk about. And that's why implants are not forever, okay? So you can have, in terms of adverse events, you can have some local events, which we talk about, and a new breast implant illness that we've just started to talk about, and I'll touch briefly on that. It's very, very early stages. So in terms of acute events, they're very rare, thank goodness. I have written this in, going down the slide is increasing surgical, like surgeon tachycardia, because none of these are good. Exposure of the implant is the end disaster of everything you've worked for. So this is a picture from a colleague. So I'm not entirely sure whether this was a pre or a sub-pec placement, but basically in this patient, you can see that her skin of her chest wall is just stretched shiny, it's full of fluid, it's erythematous. And if you have a look down here, and I hope you can see with my cursor, this area is already compromised. This skin is totally under threat. There's fluid in there. You can see a little bit of seroma peeking out, and I'm already getting stressed just looking at this picture. There's a big hole here, and I'm pretty sure that's going to be some mesh and implant underneath. This is a disaster for this patient. It's a disaster for two reasons. Obviously, having a failed implant and a loss of skin is a big cosmetic and psychological issue for the patient. But the other thing is, if you have not thought about the fact that this patient may need chemotherapy and you haven't processed the oncology as a surgeon, and you end up doing this sort of a procedure, you may be delaying the patient's chemotherapy or radiotherapy from many weeks to months. And it's a real responsibility. So when I do these procedures, it is not without risk. And this is the risk we get concerned about. It's not just aesthetics, it's actually delaying oncologic outcomes. So really important that your surgeon switched on. I'm very upfront with my patients about that. I'm sure my colleagues are as well, but it's super important that patients are aware this isn't just something that automatically works every single time. When it goes bad very badly. So acutely, the things that we worry about are seroma formation. Again, increasing pressure in that cavity, threatening that skin flap that we're worried about. Infection is obviously a problem. This patient has clearly got a super infection on top of whatever is going on inside her breast. Hematoma, we are meticulous. I have a bit of erythrocytophobia whenever I see a little spurter. Absolutely meticulous operating is important. So hematomas happen. It's impossible to prevent 100%, as any surgeon will tell you, but we are absolutely meticulous about making sure we minimize that chance. And of course, the end result is exposure of the implant, explantation, and the absolute worst case scenario is they lose the skin as well, which means they need major reconstruction with soft tissue. It's a very, very bad space to be in. But the good news is it's pretty rare. What's far more common is these multitude of cumulative sort of scar-related issues around implants. And often that's the reason for revision. And this is where that 10-year sort of expiry date, as it were, comes into being. So my role, I think, with this talk in particular is not so that you can solve a double bubble abnormality or displacement. I want you to be able to recognize them and feel confident in understanding where it's coming from, so you can refer back to someone like me or the cosmetic or well, not cosmetic, but the plastic surgeon who's put it in. So one of the most common things that we see is capsular contracture, and it's the #1 reason for reoperation on implants. And we kind of expect it automatically in most patients by the time they get to 10 years. And what happens is, like any other foreign body, you have a foreign body reaction around a prosthesis, an implant, and you end up with a capsule forming, a bit like what Cherry was talking about earlier in her talk. We like the capsule. Having a capsule holds it in place. If your surgeon's done a fantastic dissection of the pocket, fits the device perfectly, the capsule will form around the device and actually hold it in place. So it's fantastic when it happens. The problem is, over time, the capsule will start to harden and the patient can start to have pain. I bet some of you have already seen some patients in rooms who've come in complaining of breast pain after implants, or breast pain sometime like longer term after implants. That's going to be what it is, from that capsule starting to cause pain. The capsules are super hard and tight, and at a later stage they can actually cause the breasts to have deformity. And you can have a look at this lady here. You can see that her breasts are kind of she's got round implants in. It's pretty obvious, but they've kind of, this one's been displaced to the side. It's a bit lopsided over here. It's really hardened down and scrunched down. That's capsular contraction. And when you have a lot of capsular contraction going on when it's really firm, you can see that this implant is actually misshapen and wrinkled by the strength of the capsule around it. And that can actually lead to rupture of the implants because it puts so much pressure on it. We think that the primary, oops, sorry, I didn't mean to do that. We think that the primary driver for this is a bacterial infection, a super infection, which is called biofilm. I won't spend a lot of time on it. I'm happy to answer questions if everyone's interested, but basically we have a lot of different techniques that we use to try and minimize that during the time of surgery. So meticulous surgery is still key to that. I know you probably remember from surgical terms and chatting with surgical colleagues, we love classification systems. I don't normally spend time on lectures like this talking about classification systems, but the reason I bring up the Baker grades is because that's actually what I want you to think about when you're assessing one of these patients in rooms. Very simple classification systems, system of CapCon or capsular contracture. Baker grade 1 is what everyone has. The implant's soft, it's not particularly palpable. The envelope, sometimes if the skin envelope is thin, you can actually see it, but that's pretty much what you get after you have an implant reconstruction or an augmentation implant. By Baker 2, you can start to palpate a little bit. You can feel the edge of it, but there's no real deformity. 3 and 4 is when we start to get involved in terms of surgery. The implant is hard, you can palpate it very clearly. There's minor visibility, so you can see some change in the shape, rippling on the skin. And if you do an ultrasound on these patients, you'll actually see the infolding on that. Baker grade 4 is usually, by that point, we want them back in theatre to solve the problem for them. Patients are often really uncomfortable, the implant's super hard, and at this point there's quite a lot of folding, and sometimes you can even see the rupture, and by this point the malposition has usually brought the patient back to us anyway. I won't spend a lot of time on the biofilm in the interests of time, but basically these are some of the multitude of things that we have out there for surgeons to optimize capsular contracture. Another common thing that you may hear about or see when you send off a patient to have an ultrasound, and I certainly see in rooms when I get referred from my GP colleagues, is the idea of implant rupture. And this scares lots of people, from medics to patients. It's not that scary, actually. So you can have intracapsular or extracapsular rupture. And what we mean by that is the implant rupturing within that capsule that we talked about, or sometimes it ruptures within that capsule and makes its way out of it. And this is why that tight grade 4, Baker grade 4 capsule can be a real problem for patients. It can be silent. You can have ruptured implants for years and not realize if it's an intracapsular small rupture. But what you can see as it worsens is an associated like a change in the shape or the projection of the implant. It's not an emergency. An extracapsular rupture is, should be seen emergently by someone like myself or the patient's plastic surgeon to assess whether or not they need early intervention. And intracapsular rupture is not an emergency. We can fix it up, but it's usually held within. And we call it the linguini sign. You can actually see the squiggles on the MRI at the top. And down here is an ultrasound showing this little lump of silicone. That's the dark stuff here, that little lump there, of an extracapsular leak. And you can actually see a little bit of the infolding of the implant here, actually, with your eye of faith, perhaps. And an extracapsular leak, of course, can present as an acute foreign body reaction. In terms of things that you might see patients come in with, this is quite some extreme examples, I suppose, but they can come in with visibility or movement. We call this a double bubble deformity. Surprise, surprise, not difficult to know why we called it that. But basically what happens is that the patient's implant bottoms out, and it needs revision to fix this deformity. You can get synmastia, which is if the surgeon has dissected too close, the left and right pockets too close to each other in the midline. We usually leave a centimeter or so. It's a bit of a judgment call. You can definitely see the pectoralis take off, and you try and avoid that. But if someone's not careful, they will come to the midline and the patient will end up with this sort of monoboob effect, which is not good. You can see rippling and the palpability, meaning that kind of ridginess that the patients start to see and feel. And animation, although it's not always a problem, it's specific to if you put an implant underneath the muscle, the subpectoral implants. If the patient flexes their pec muscles, the implant can move. This is particularly an issue for people who are, women who are sports people, or who are very particularly fit or have very well developed pectoralis muscles, and it can be worrisome for them. So those are things that we can do to fix that up. In terms of breast related adverse events, probably this is basically the changes that happen to breasts that mean that you need to revise your implants. And parenchymal ptosis is a fancy way of saying your breasts continuing to droop, the breast gland continuing to droop while the implants are in place. This is something that you see in the augmentation world. Obviously, in my patients who've had their breast tissue removed already, it's not quite the same thing. They can get something like this, but it's slightly not quite the same origins or pathogenesis, I should say. But what they get is this waterfall deformity where you can actually see the breast drooping down and the implant remaining in place, and or it can be called the Snoopy deformity. I prefer waterfall deformity. Patients can of course present with breast pain, benign breast lumps, and of course breast cancer, which all need to be managed and may require the removal of implants. So now onto the big one, which everyone wants to know about, which is BIALCL, which is breast implant associated anaplastic large cell lymphoma, which it's a relatively new disease in that it was only recognized in the last few decades, and it's got a rising incidence because as we're putting in more and more implants, we're finding more and more of this. It's not common. but I believe that the incidence is going to keep rising. It's essentially a T-cell lymphoma that's related to the breast implants. And remember way back in one of the early slides, I spoke about the texture of the implants, whether it's textured or smooth. We found that with the highly textured implants, so some of the early implants were actually covered in polyurethane foam. And actually, I'm just out of theatre. We just removed a pair of those today for explantation. She didn't have BIALCL, but you could really see how it grows into that matrix on the surface. And we think that there is something that sets this reaction off, and you get a T-cell lymphoma forming. The classic presentation is a late seroma. So that means some years further on down the track, the patient suddenly feels a swelling in their breast, or alternatively, they might have their annual mammogram and ultrasound, and suddenly there's a seroma found. And that's a classic presentation. And we'll talk a bit about the workup for this. Very less commonly, they present with mass-forming disease. The prognosis is not bad if it's found early. We basically have, and I mean, these quite early days for us to give, we can't really give long-term follow-ups because the case numbers are just starting now. But essentially, if it is contained within the capsule and in that seroma, if we do a total capsulectomy, so again, meticulously operating and removing the entire capsule and the implant in situ with that, that is all the treatment these patients need. So the good news is the vast majority of patients in Australia who've had this were able to do that. Unfortunately, for those where it's progressed a little bit further, the outcomes is not quite so great. The classic BIALCL clinical presentation is something like this. So this woman, you can see that there's her left implant, but her right implant suddenly has almost doubled in size in this case. The lady below you is a little bit more subtle. It's still larger on her left, but it's not as dramatic as the woman on top. This is an MRI scan showing two things of interest. One is this shape here. That's her implant, and it's floating around in this huge pool of seroma. And the other interesting thing is here is her other implant, and you can see it's quite misshapen and it's got some wrinkling in it, and I suspect that she has a pretty decent capsule contraction going on there. So when we operate, this is similar to what we take out, and interestingly, this implant with the blue line, these are the polyurethane implants I was talking about. We take it out in its entirety. That's what the capsule looks like when we take the implant out of it. And here you can see just holding up the implant pocket of the capsule. We've dissected here on the outside, and there's the pocket where the implant used to sit. So we've had about 100 cases or so, a few from overseas as well, fairly young patients, and the mean exposure time is about 6 years. You can see, 7 years. Haven't really seen too much bilateral disease, but this is very much an emerging space. So in terms of, I won't dwell too long on the unifying hypothesis of this. Sorry, let me go back to that slide for a minute. In terms of your workup for these patients, we'll talk about that at the end as well. But essentially what you want to do is, if you have someone coming in seroma like this, start off with an ultrasound. If there is fluid there, please ask for an aspiration of that fluid. Generally, if you send the patients to a breast-specific radiology place or a radiology place that has a breast interest, and I highly recommend that you do, these patients, the radiologists will know what to do with that fluid. But just in case, I always, I'm a bit pedantic with my platforms. I write down exactly what I want pathologists to look for. There are two things you need to do. You need to ask for cytology, especially CD30 markers, looking at that, because that's quite specific to BIALCL. So some of the fluid needs to go to cytology, and because sometimes you can have infections in there as well that can muddy the waters, some of the fluid needs to be sent to microscopy, culture, and sensitivity. So if you write that in your request form, you know that whichever radiologist gets to this patient, they'll be able to deal with that for you. Absolutely, if you see something like that, you should be referring them back to a breast surgeon to have a look. And generally, I would organize the MRIs. We're very lot of lobbying by a lot of senior breast surgeons has resulted in government giving us some rebates for patients in this situation. So we are able to get order some rebated MRIs for them as well. In the MRI, we look in particular for a very thickened and bright capsule, which is one of the radiological signs, along with seroma, of BIA-ALCL. If the seroma volume is not very large and it's not amenable to aspiration, it's probably going to be physiologic, but even then I tend to observe these patients for a period of time and make sure that it doesn't increase. Obviously, if it's not amenable to aspiration, then it's probably the only way of getting into that area is through surgery. So let me get through that. Sorry, I don't know why it's animated like that. So this is, don't worry too much about this slide, but I just wanted to show you that now at the end of that, you've actually got a pretty good overview of how to handle a patient who walks into your room with an implant, whether it's for reconstruction or for an augmentation. You know about capsular contracture and the different Baker stages and what they might present with, and that you can have rupture from that. You know how to see and note a waterfall deformity. You know that a late seroma must exclude BIA-ALCL and that immediate swelling that you get. You also know about visibility and rippling and double bubble and some of those more cosmetic things. Now this is I won't spend a lot of time on this one, but it's a new recognition, a little bit like what Cherry was talking about with the query autoimmune kind of general symptoms that people have been complaining about, meshes and so on. And we've got this new breast implant illness that people are talking about. And when I say people, it's you know, social media and you know, all these augment patients and stuff talking about a whole host of different symptoms. I have a feeling that this is just going to be a growing space. This has kind of led to the growth of an explant expert, as it were. So I have started doing some of these explants as well, and there are a number of patients who just want to have it removed. And interestingly, when they have these implants removed, they somehow, they actually have positive response with all their symptoms. It sounds a little bit airy-fairy and not pinned down and look for a surgeon. It kind of is, because I can't see the data. But we've actually started a prospective trial at the study, I should say, at the moment, and we're sort of recruiting. It'll take many years, of course, but the idea is to log some of these symptoms and things like that. So that's where your history taking in your GP practice, of course, is going to be very helpful as well. So we've talked about that. We're on to the last section, last stretch home. This is the bit that you came for, since I know you've given up your evenings for this. This is my goal, to get you comfortable with taking a history and assessing these patients. I'm not going to spend a lot of time on general breast history because I'm sure you know how to do all of this. Basic breast history includes a reproductive history, obviously a family history of breast cancers, lymphomas, autoimmune diseases. They're all important. Any of the recent imaging results, assistance review, in particular with respect to all of these symptoms that we spoke about earlier with the breast implant illness. Good to know if they have any systemic issues. This is what I'm interested in as a surgeon. And look, I don't have a problem if you forget to take this or you don't have the time for it, it's fine. But this is the information we're really interested in my practice, and I think in most surgical practices in Australia. When a patient gets an implant or a device placed, so even if they're having a temporary tissue expander, I give them their information on a card, just like with your you know, pacemakers and all the other bits and pieces that we put into people's bodies. And all the implants come with a little card and unique identifying stickers and barcodes. We register them into the Australian Breast Device Registry as well, but patients should have that information with them. I try and put it on, I always put it on my op report, and I CC my GP colleagues into it so that that's on their record as well. Just so, you know, we've all got the same information. I'm a big fan of making sure everyone is informed of all the details around a patient's care. Even if you don't need it, you never know when you might need to dip into that info. The key things are really indication for surgery. Was this a recon? Was this cosmesis? What was the reason that they had this procedure, implant put in? The date of the procedure. Look, you don't have to know the exact date, but if you tell me that it was done in 1996, there's a big difference between that and telling me it was done in 2015. The implant brand and type, if they know it, and lots of patients actually don't, sadly, especially the ones who've been done overseas. Mentor, for example, is a very common implant brand. They might know that. They'll know whether it's a, they may know if it's a silicone or a saline, the size, shape, and surface, as we talked about before, if you can find that out, whether it's in the pre or subpectoral space, and really importantly, and I'm sorry about the typo there, the name of the surgeon and the location of the surgeon, because that's who you want to send this patient back to. Not always possible if the patient's been operated on in Brazil or the surgeon has retired or something like that, but it really gets us a feel for the implant specifics. Symptoms that you can ask for now that you've heard all of those different complications that can happen: pain, change in shape, the hardness around there, any palpable masses, of course, very important, deformity of the implant or the shape of the breast, any nipple areola complex, that's what NAC stands for in my world, nipple areola complex, and skin changes or any nipple discharge. All those things are very important. When you examine these patients, again, it's not rocket science. You inspect the patient, you palpate the patient. When you inspect them, I start off, you know, I'm sure you've done like a million breast exams. I'm just going to run through how I do it, just so that you know what I do. I sit the patient up when I start off. I always start with them sitting on the edge of the bed, which lets me see what the symmetry is like. I ask them to raise their hands straight up in the air. It shows me any tethering or other contour defects. This is with my breast cancer patients as well. I ask them to put their hands on their hips and press down hard so they flex their pec muscles. It lets me in cancer patients look for any tethering, or in these implant patients, animation and capsular contracture. Obviously, when you're palpating the breast, you're looking for any lumps, whether you can feel the implant, the capsular contracture, and you always need to check the draining lymph nodes, which is bilaterally the axilla and the supraclavicular foci. When you're palpating the breast, I've had lots of people actually ask me, you know, do you go in a particular order? Look, I don't really care how you do it, as long as you're consistent and that you are systematic. So I like clock faces because I'm a breast surgeon and we talk in clock faces. Clock faces in breast, 12 o'clock, 1, 2, 3, 4, 5. So 3 o'clock in the right breast is actually medial. 3 o'clock in the left breast is actually lateral. Okay, it's just like 2 clock faces, but I just go through each quadrant of the clock face. I feel the surface as well. I feel along the sternum and the lateral aspects, and don't forget that the breast actually extends into the axilla, so you want to check that area as well. And in my reconstruction patients or my post-cancer patients, I really like to check their arm movement. They can often get a bit of cording, and which is scarring under the arm, and it's probably a good idea for you to do that. I certainly do not expect my GP colleagues to be there taking clinical photographs, but that's what I do in rooms from these angles to give me a full view. And our patients are very used to having their pictures taken before and after surgery, and we keep following them up for many, many moons to see how they're going. In terms of investigations, this, if I can't, of all the investigations, one I get asked all the time is about mammograms and implants. Mammograms and implants do mix. It's absolutely fine to do a mammogram on a patient with implants. It's completely safe to do so, especially if you send them to a radiology practice that does a high volume breast thing. In fact, in augmentation patients, mammograms are actually even better because the augment has actually pushed the breast tissue forward into the X-ray space. So absolutely do not skimp on mammograms just because your patient has an implant. That is old school thinking, and you will get pushback from sometimes even from radiology, if you send them to a place that's unfamiliar with managing patients with breast conditions. But absolutely do not skimp on screening for these patients. For implant patients, for the augmentation, basically implant patients get annual surveillance because they need to be checked out for all of these things that we spoke about. My breast cancer patients get annual surveillance because of their breast cancer anyway. So often the recon patients are plugged in with their surgeons. It's these cosmetic patients that I worry about sometimes, especially the ones who haven't perhaps seen plastic surgeons necessarily invested in that. So sometimes with those cosmetic centers and so on, they don't necessarily follow up their patients like that. So annual surveillance is important. The downside is at 20,000 plus implants a year, there's no way that specialist breast surgeons can take on that volume in terms of implant checks. So it actually is going to become more and more of something that you have to get familiar in the GP space. And in terms of their surveillance, breast ultrasound and mammograms are fine. MRI is usually something I would organize after I see the patient because it's a very specific test and I use it quite judiciously. These patients need to be educated that they need to be surveilled for their risk of breast cancer just like the rest of the population, and that it is okay to have normal screening. So if they are fine to have mammograms, they're fine to have ultrasounds, and obviously if they happen to have a symptom such as a breast lump, they need to have the same investigations and workup that any other patient would receive. In a timely fashion, New South Wales Health has just released an actual clinical approach to assessments of patients with breast implants, and I believe this was sent through to RACGP as well. One of the RACGP people might be able to tell us more about it. I'm not going to spend time on it, but this is basically a summary of everything that we've talked about, a bit of a flow chart for you to work off of. It's on the New South Wales Health website, and I'm so sorry I have the link, but I will send it through with Lydia. I basically have a couple of take-home messages here, nearly at the end. Implants are really common, and you're going to see some of these issues in your rooms guaranteed. They're going to need annual review, and you're going to need to do some of it. But the good news is you now have all the tools to assess these women. The other thing is, if you want to upskill in all of this, just let me know. My new practice with Integrated Breast Health in Miranda, we're actually recruiting and upskilling GPs in breast healthcare, and we've already had 4 GPs who've been trained through that. But if you just want to upskill in some of this stuff, implant checks, all of that stuff, I'm very, very happy to help you out with that. But this is the most important take-home message of all. Call me anytime you need. Don't hesitate. As a specialist, I'm here to help you manage our shared patients, right? So some of you who might be on who already work with me know that you can have my mobile number. I'm very happy for you to ring me at any time. I've done surgical training where you get rung at 3 a.m. 15 minutes at a go. I've got 2 little kids. They wake me up all the time. So really, you can ring me. I don't mind if it's after hours or not. Because this is online, thanks to COVID, I would normally give you my mobile number, but I'm very happy to give that to Lydia and she can give that to you. And if you have any questions at all about this or any other breast conditions and so on, I'm very happy to help you out with that. And obviously my Miranda rooms and Lifehouse rooms are over here. And yeah, you can email me on that as well. But that's it.
Thank you very much, Dr. Nipa, for such a comprehensive presentation. Would you mind answering one question? Most of the questions has been answered as they've been coming in. There is a question on patients who have breast implants after mastectomy. Should they be followed up for life by the surgeon for implant complication, as normally the breast surgeon does not follow up after 5 years post breast cancer if they are disease-free?
Okay, that's a question with a couple of answers. The first answer is the 5-year cutoff for the breast surgeon not following up a patient is a personal choice that a breast surgeon makes. So generally, I would follow them up for a bit longer than that. I normally would follow up I offer all patients ongoing follow-up if they want to stay with me. So let me go back a little bit. In someone who's had a wide local excision, in other words, they haven't had an implant and they've got their own breast tissue in place, breast conserving surgery, I would generally say, look, I'd see you for 5 years, and I'm very happy to keep seeing them if they're comfortable with me. If they want to go back to their GP, they don't need to come and see me. But I never discharge them from my rooms per se. It's more giving them that option. That's the patients without implants. Patients with implants, absolutely, I would be following them up for the duration of my career, certainly, because it's my device. I put it in, they're my complications. I do not expect anyone else to sort those things out. And I really think that there's a problem. I mean, this is my personal sort of clinical philosophy. I think if a patient comes to me, is referred to me directly, it's my patient, and I don't expect, I expect my GP colleagues to be able to pick up the phone and give me a call if there's a problem, but I certainly don't expect them to take on the follow-up for these reconstruction patients of mine. The issue is primarily going to be augmentation patients, and that's what I mentioned earlier in the talk. Generally, the cancer patients are plugged in with their surgeons. The augment patients, on the other hand, they come from a range of different sources. And, you know, I'm not disparaging my plastic colleagues, but there's a big difference between cosmetic plastic surgeons who do just the augments and perhaps don't have a longer term follow-up in place, and then plastic surgeons who have an interest in explantation and follow through. So I hope that answers your question. The simple answer is, in my practice, absolutely, I follow up all of my recon patients and my implant patients. I can't speak for other practices, but I would hope that you are able to pick up the phone and be able to speak to your surgical colleague about any issues that you have got going on.
Mm-hmm. Thank you very much. And one last, annual review for breast implants. Is this examination with GP only, or should they have mammogram and ultrasound?
So I'm sorry if I wasn't clear before. That's a great question. I was trying to be clear about it. They should be having mammograms and ultrasounds. The mammograms will last you for 2 years if there's no abnormality to be seen, but an annual ultrasound as a baseline is necessary. If these patients are in the screening age, and breast screen is from age 50 to about age 70, remembering that it's a public screening program, the invitation is from 50 to 70, but you can absolutely start breast screening earlier, and you can keep going with breast screening, you know, later on. So for the augmentation patients, you can start the screening process appropriately. If if you have a young augmentation patient, you can start off with a baseline mammogram and ultrasound with ongoing annual ultrasounds and clinical examination. For an older patient who fits into the normal breast cancer screening pathway, I would say 2 yearly mammograms and ultrasounds as per normal, plus annual 2 yearly mammograms, annual ultrasound, and examination annually. And then obviously for the reconstruction patients in my practice, I would see them annually. Because they're cancer patients, they should be seen annually anyway. Reconstruction patients, remember, it's a bit tricky to remember sometimes, I forget as well, they don't have breast tissue. So you're not actually ultrasounding or mammogramming breast tissue per se. So generally a chest wall, we say chest wall ultrasound, we actually don't say breast ultrasound because it's not a breast. Chest wall ultrasound is all they need. And sometimes they don't need that either. A clinical review can be sufficient.
Comment.